biomechanics talk today. We're slowly kind of sneaking our way into this seminar series, so it's a pleasure to introduce Stephen Capehart. So Stephen Capehart's a TA, and he teaches the undergraduate biomechanics labs. He's also our lab manager, so fixes everything and helps everyone out. He started his career at the University of Cincinnati, so he did a BS in health sciences. Moved on to Barry University in Miami, where he did his master's, focusing on sort of ACL injury mechanisms, looking at drop jump landings. And so the work, his future goals are to be a professor, right, assistant professor, teaching and conducting research. So the work he's going to present today is part of an independent study that he conducted last fall and presented this at the national meeting like the American Society of Biomechanics. I'll hand it over to Steve.
All right, so the title of the presentation today is The Effect of Hip Abductor Fatigue on Frontal Plane Kinematics During Walking. So first, I just want to start off by, if you ever get a chance, runners are a great population to study. They're highly motivated, they're very interested in the science, and they're always getting injured. So you have a constant source of someone to study. Also, for biomechanical purposes, they're very lean usually, so easy to study mechanically. Like I said, they're injured a lot. 27 to 70% of runners may be injured, experience an overuse injury each year. And you know, when we say overuse injury, this is kind of a result of chronic or cumulative microtrauma. So runners rarely are going to be having an acute injury. It's going to be a kind of chronic result of repetitive stress. Okay, so what are the exact causes of these overuse injuries? Still remains kind of unclear. What we can say for sure is that it's probably multifactorial and also diverse. So here we got a theoretical model of three kind of main factors that will contribute to overuse running injury. So the first one, which some suggest is the number one factor, would be training. So runners are notorious for training too long, running too too hard, and not listening to their body when they kind of tell them, hey, maybe this is too much, and maybe I should back off a little bit. We have some anatomical factors. These are really out of our control. These are kind of genetic factors. Some look at arch height, some look at pelvis width to femoral ratio, so stuff like that where you don't really have control of it, but it may be contributing factor to why you're more prone to injury. And lastly, we have biomechanical, so that's what we're interested in the lab. We can look at kinematics, so the angles, velocities, displacements. Kinetics, we can look at the ground reaction forces, joint torques. We can also look at EMG, so the muscle activation patterns of runners. All right, so the knee is the predominant site of injury in runners, and some studies have suggested up to 50% of all lower extremity injuries occur at the knee. This most often is a result of movement out of the sagittal plane. So the sagittal plane, you move forward or backwards. So running is a predominant sagittal plane movement. Additionally, the knee is a sagittal plane joint, so it just flex and extends. So anytime you get out of that sagittal plane in the frontal, side to side, or the rotational, transverse planes, you might be increasing your risk of injury. And the two most common knee overuse injuries we see are what's called patellofemoral pain syndrome, or PFPS, and iliotibial band syndrome, ITBS. And of course, with all the research I look at, injuries are twice as prevalent in female runners compared to male runners. All right, so initially we're wondering, why is there the gender difference? Why are female runners injuring themselves at a much higher rate than male runners? So this study at Calgary is Reed Ferber. He's got two studies, and it's about a total of like 280 females versus 240 males. And they've noticed this trend, this consistent trend, where female runners are landing with an increased hip adduction. So this tries to show you the hip adduction angle there, where it's just kind of how the femur moves medially or kind of moves towards the midline. So that's hip adduction. And this is a mean ensemble curve from that study, and this shows the whole pattern of females, this dashed line, versus this solid line, males, during the whole stance phase. So female runners have a higher adduction at contact phase, they reach a higher peak during mid-stance, and then around push-off they get to the same, almost neutral position. Alright, so what's the mechanism of an injury? Why might this hip adduction be bad? So for iliotibial band, you have this long tendon. Your iliotibial band runs from your gluteal muscles, your TFL, and inserts down on the lateral side of your patella. When the IT band is in an abducted state, it's kind of in a loose position. On the contrary, when this IT band is in an adducted state, it's going to be stretched, or it might be in a state of tension. So if you run and have excessive hip adduction, it's thought that it might cause constant tension on the IT band at the knee. Additionally, this tension on the IT band might cause what's called maltracking of the patella. So the patellofemoral joint, your kneecap, can maltrack or can shift laterally as a result of tension on the IT band, as well as hip adduction might cause knee abduction. That's when the medial compartment of the knee opens up, the lateral compartment of the knee kind of compresses, and it might cause what's called this abnormal Q angle, and that also might shift the patella and cause that patella maltracking and be kind of one of the reasons for pain at that joint. Alright, so now that we have this mechanism, what if we study healthy versus injured runners? So 4 studies here who looked at, 3 of them looked at PFP and 1 looked at ITB band syndrome, ITB injuries, and compared those to healthy runners, and all of them found the same thing. The injured group had an increased hip adduction angle on landing. So 3 other studies just looked at hip abduction strength and noticed in PFP and ITB injured runners that they had reduced hip abduction strength. So combining these different studies, there was this kind of proposed relationship between strength and kinematics. So the proposed relationship is that if you're weak in your glutes, your abductors, weakness in this muscle group may cause excessive hip adduction as you're landing. And why is that? During the first half of stance, the abductors are acting eccentrically to control that motion of the hip. So they're eccentrically controlling that hip abduction. If you're weak in the hip abductors or fatigued here, you can't control that motion and you might land in an excessive adducted state. So, this relationship appeared to be evident during running, but there's another question, do we see this during walking? So this was actually a study by Dr. Pohl where he injected a nerve block, I think it was a lidocaine injection into the gluteal nerve here. And what that did is it reduced the strength of the hip abductors by about 26%. This pretty significant reduction in strength actually resulted in no change in kinematics during walking. So even though they were weak in their hip abductors with the injection, they still maintained that normal hip and pelvis kinematics during walking. So there's other studies that just compared healthies versus injured walking. And I think Dr. Pohl's got one of these and one of these, so he's all over this presentation, you'll notice. But patients with PFP display similar hip and pelvis kinematics to healthy walkers, as well as patients with knee OA In this study, they found even though the knee-OA patients had weaker hip abductor strength, they had similar hip and pelvis kinematics. So we were thinking there might be this interaction between walking and running where maybe walking is not a demanding enough task. So maybe walking, you can have a weak hip abductor and it's not going to change your hip or pelvis kinematics. Whereas running, more demanding task, weakness in there, you're going to have that excessive frontal plane motion at the hip. So the purpose of this study was to determine the effects of hip abductor strength on frontal plane mechanics during walking and running within the same group. And the hypothesis is that we believed, following the hip abductor fatigue protocol, that our runners would have that increased hip adduction, but not our walkers. Our walkers would have similar hip and pelvis kinematics. So in our study, we had 35 female runners were recruited. The mean age was about 28 years old. Our inclusion criteria was anywhere from 18 to 40. We just said you had to run for at least 30 minutes 3 times a week. So this is definitely a kind of recreational runner. Our exclusion criteria was no history of injury to the lower limb or back within the last 3 months, and then no history of lower limb surgery or back surgery ever. All right, and then here's our experimental design. So we had the subjects come in, they would do an initial hip abduction strength test. After that, we would look at their pre-fatigue gait analysis. Then we would employ the fatigue protocol, followed by a post-fatigue strength test, did a post-fatigue gait analysis, and then finished with a post-task strength test. All right, so the strength tested, we used a Biodex isokinetic dynamometer. We did 3 MVICs lasting approximately 5 seconds each, with a 10-second rest in between. And again, we measure these values pre-fatigue, post-fatigue, and then post-task. One of the unique parts of this study is we're one of the only studies I've seen that have analyzed fatigue post-task. So a lot of fatigue studies will analyze it post the fatigue protocol, but not after the task. So you can actually recover from fatigue pretty fast. So we wanted to see whether our runners or walkers were recovering within that time period during the study. All right, so a gait analysis we did over in the biomechanics lab. We have a 10-camera high-speed motion capture system where we put reflective markers up and down your body, and then we can use these markers to create a skeleton. And with this, we can get out our kinematic kinetic data. Our subjects walked at 2.2 miles an hour and then ran at 6 miles an hour for 3 minutes. And they did this both pre and post-fatigue, or post-fatigue. They were only running for 30 seconds and walking for 30 seconds. All right, so the fatigue protocol. This is a hip abductor fatigue protocol. So we had the subject on the plinth doing sideline raises. We set this target, it's about 20 degrees of hip abduction. And they would do this 3 sets till failure. So they would do this until they couldn't hit the bar 2 times in a row. We'd give them a 30-second break, and then we asked them to do it 2 more times. So they were pretty fatigued, they were pretty hurting after the end of this. Also, if you notice here, we did add an ankle weight, and that's because through pilot testing, Dr. Pohl's wife, Chandra, was going forever. So we're like, we don't want to stay here all day, so let's add an ankle weight, make this harder, so they fatigue fast. All right, so data analysis, what did we look at? We looked at peak hip adduction and excursion angle. And we also looked at the pelvic drop. So contralateral pelvic drop can also cause that hip adduction. So we looked at both of those variables. And we did a two-way repeated measures ANOVA and comparing the peak angles during pre-fatigue and post-fatigue, both during walking and running. So one of the most interesting parts of the results of the study was that out of that 35 subjects we recruited, only 19 met the fatigue criteria. So to meet the fatigue criteria, you had to be at least 20% reduction in hip abduction strength. So only 19 of 35 subjects were still in a reduced hip abduction strength post the task. So here are the hip abduction strength results of our 19 subjects who met that criteria. So from the pre-fatigue analysis to the post-fatigue, they had a 39, almost a 40% reduction in strength. So after the fatigue, they did their post-fatigue gait analysis and we re-measured them, and these subjects were still at 29%, so still pretty fatigued. This was a key thing we measured in our study as well, is from the instant that they stopped the fatigue protocol to the instant that we measured them again post-task, it was about 5 minutes. So 5 minutes might seem like a long time. Within that, they were doing two MVIC tests as well as walking and running. But still interesting that within 5 minutes, almost half of the subjects recovered from that fatigue. So if you're ever going to do a fatigue study, it's really hard to simulate fatigue and make sure that they're still fatigued. All right, so results, we found no significant interaction effect. We did technically find significant main effects for hip adduction. So this was statistically significant where runners initially have, pre-fatigue runners had 18 degrees of hip adduction versus walkers who had 11 degrees. And post-fatigue, they actually decreased in hip adduction a little bit, which is the opposite of what we would have expected. We would have expected them to increase. But this change is actually less than 2 degrees, so that's about 1.5 degrees. So first of all, that's going to lack clinical significance. So if I change 1.5 degrees, that might not mean anything clinically speaking. As well, our 3D motion capture system has about a 2-degree error, especially in frontal plane measurements. So we don't really have confidence saying that was an actual reduction. We were going to lean more towards no change in kinematics, pre versus post fatigue. Additionally, no significant effects for the pelvic drop, where we see pre-fatigue, running, post-fatigue, doesn't matter. The pelvic drop is pretty similar between all the conditions. All right, so we actually looked at some other things. So compensatory strategies, also called like gait avoidance patterns. So if you have pain or you're injured, you might try and compensate by moving somewhere else. So in this case, if you had pain in your hip abductors, if you were fatigued in your hip abductors, you might try and increase your what's called ipsilateral trunk lean, and this might be a compensatory strategy to reduce the load on that hip abductor. But we measured this and really no difference there as well. Another compensatory strategy is step width. So the study out of Tennessee by Milner showed that if you increase your step width during running, you can decrease your hip adduction by 3 degrees and decrease the torque at your knee significantly. So we measured step width as well just to check if our runners did this compensatory strategy, but we didn't really find any difference here either. All right, so discussion, we expected an increase in the peak angles following running, but not walking. However, we didn't really see any change in kinematics despite that reduced strength in the hip abductors. So yeah, despite 29% reduction in hip abduction strength, no change in the kinematics during either walking or running. So as this compared with kind of other studies, looked at the literature. First of all, there's multiple ways to study a weak hip. There's one study here by Dirks where they looked at PFPS patients and they had them do a prolonged run. So they would run on a treadmill until they met one of the three criteria. It's like 85% of max heart rate or like an RPE of 17. This study actually showed that the reduced strength in this PFP group resulted in that altered kinematics, so that increased adduction, potentially increasing the risk of injury. However, in healthy subjects, we've got 3 different ways to study hip in healthies. No differences in kinematics despite the reduced strength. And real quick, I'll just talk about how else you can simulate a weak hip. This strategy is done by a couple studies did this where they actually recruited over almost 150 subjects. You come in, you do your initial hip abduction strength test, and then once you have your 150 subjects, you go back and you look at the 10 strongest versus the 10 weakest, and you ask them to come back in the lab and do a kinematic study on them. So this has been done in walking and running, but again, despite our strong group versus our weak group, they still had very similar kinematic results. The nerve block, that's a study talked about Dr. Pohl. That's another way to look at it. No difference in kinematics. And then isolated muscle fatigue protocol, that's what we did, where we tried to analyze isolating that hip abductor strength. And we looked at walking and running, and the only one of the kind of studies that I've seen to try and isolate hip abductor fatigue and specifically look at how it changes your kinematics during walking and running. So what else might be going on? So we're looking at other things, we're scrambling to try and see what's going on. There might be an anticipatory strategy. And this is the mean ensemble curve of the hip adduction during pre and post fatigue. And you notice it's a pretty similar curve, looks like a pretty similar excursion. It's just there's a difference at initial contact, where we believe maybe the post fatigue, the fatigued hip abductor runners, maybe did an anticipatory strategy where they tried to land an increased abduction at initial contact. So there's a previous study by Wilson who actually showed that in healthy female runners compared to male runners, that the female runners had an increase in gluteus maximus activity at initial contact. So this muscle activation pattern may be an anticipatory strategy to reduce the demand of the hip abduction. All right, so hip abduction strengthening programs. So there's multiple studies that have looked at 6 to 9 week strengthening programs to see if increasing the hip abduction strength will change the kinematics. So this first study, 15 healthy women, 6-week program of just doing hip abduction strengthening exercises. Saw a 13% increase in the strength, but again, no change in the kinematics. This study was pretty unique where they pre-screened and found healthy women who had excessive hip abduction, so greater than 20 degrees, which is a lot, and you'll see in mostly just PFP or ITB injured subjects. So they were able to find 12 of these female runners. They had them enter a 6-week program, showed a 41% increase in strength, so but they actually showed no change in kinematics. One note on this study is pretty crazy. They asked their runners to refrain from strength training for 90 days prior to the study. So these runners did not do any kind of strength training for 90 days, and that's most likely why you're going to see that huge increase in strength. But again, did not change their kinematics. They still landed with 20 degrees of hip abduction. Lastly, a study looked at PFP patients, PFP women, 9-week program, found a 12% increase in strength, also reduction in pain, so it seems like it's alleviating the symptoms. Improvement in functional ability or functional activity, so they were more active, but again, they found no change in kinematics. So, future research, why do we keep seeing this increase in strength but no change in kinematics? One of maybe the limitations of research is that we keep looking at peak isometric abduction strength, where during running, how important is peak isometric abduction strength? Realistically, it's probably more of an eccentric strength that's important, which we can measure with an isokinetic dynamometer that we have in the biomechanics lab. Why do they constantly look at isometric strength? My guess is because you're always trying to relate this to physical therapists. If a runner goes to see a physical therapist can do a manual muscle test, or they might even have access to a handheld dynamometer, so they can measure abduction strength and kind of analyze that, but not many people have access to a biodex and isokinetic machine. Endurance, I think maybe the endurance of the muscle is more important, but I actually did a little sub-analysis and looked at those who fatigued and those who recovered. They had about the same time to fatigue. So the fatigue protocol, whether you recovered or you didn't, they lasted about, I think it was about 4 or 5 minutes total. So something I think we looked at, in hindsight we wish we did, we looked at the EMG, the muscle activation patterns, to see maybe that can tell us what's going on. So we looked at the hip abductor, EMG, maybe that can lend more insight into what's going on with this relationship. And I know now they're starting to look at previously injured, so runners who may have had PFP or ITB recovered, and now they're kind of trying to compare them to injured and to healthies to see if they can kind of figure something out there. So conclusion, peak isometric hip abduction strength did not induce kinematic changes during walking or running. So I think there's a lot of research into this area still left to be done. And acknowledgements, my co-authors, Michael Bagley, Dr. Pohl, and then some research assistants, Jeff Metler, Amanda Ransom, and Jill Estes. That's just a cool picture.